Welcome back. Today we'll be talking about the treatment of rheumatoid arthritis. Now, to better understand how and why rheumatoid arthritis is treated the way it is today, you have to go back in history a little bit. Now, before the 1950s, there was not a lot of medication to treat arthritis in general. It was actually just high dose aspirin. And I'm not talking about the 81 milligrams of the baby aspirin or the 325 in the regular aspirin that we see today. I'm talking about thousands of milligrams of aspirin multiple times a day, which led to, understandably, a lot of problems. Then in the 1950s, prednisone or steroids get produced. Prednisone does great for the rheumatoid arthritis patient because it takes away their swelling, it takes away their pain, they can do everything again, and it makes them feel better. Unfortunately, prednisone has a lot of side effects. It can make patients gain weight, it can have them develop sugar diabetes, cataracts, weak bones, and mood changes. So then we have the development of methotrexate. Now, methotrexate is a medication that was first used for childhood leukemias for cancer patients, but then it is also used in rheumatoid arthritis as a steroid-sparing agent, meaning that it can do the job of the steroid without the steroid side effects. And on top of that, it actually prevents deformities. It prevents those permanent changes. Now, over time, in the 1990s, we see the biologics, which are the fancy ones that you see on TV, the Enbrel and the Humira. And ever since then, we've seen a lot of medications for rheumatoid come out. And over time, rheumatologists have noticed that those patients who get treated with more medication upfront and with different combinations do much better long term. And upfront meaning within the first 3 to 6 months. So in 2010, there's a recommendation made called Treat to Target in Rheumatoid Arthritis, meaning that those patients with rheumatoid arthritis early on in their disease, specifically about 3 to 6 months, if you can get their disease controlled or well controlled within that first time period, they do very well long term. They have less deformities, and also they may also have less extra articular damage, meaning that rheumatoid arthritis is not just limited to the joints, where it also attacks the eyes and the lungs. You get less of those problems too over time. And the treat to target model also shows that patients who feel better on medications long term are more likely to stick to their medications or keep taking it on a regular basis, and hence prevent even further problems down the line. Now, as a patient, I completely understand that it is scary to go to the doctor for one disease and to come back home with a bunch of medications that have all these toxic side effects that you read about on the internet or from your friends, etc. But as a physician, I will tell you that in my own lifetime, I have seen rheumatoid arthritis patients go from being barely functional, only being able to do things around the house, to completely getting their life back. Rheumatoid arthritis patients that don't have the deformities that we saw before. Rheumatoid arthritis patients that are having less problems down the line as they age out as a population and they get less problems long term. Also, as a physician, as a rheumatologist, when I speak to my patients about these medications, I tell them, look, steroids are just a bridge. They're just there because steroids really reduce the inflammation very quickly, and then it gives us time to start the steroid-sparing agent, and as that builds up, then we can back off on the steroids. And our medications are used at different doses and in different ways for our diseases. So take the example of methotrexate. We use a pinch of it for arthritis. The abortion doctors use a cup of it for abortions, but the cancer doctors use a jug of it for cancer. So our side effects are much less than those other two classes. We have patients take vitamins, we monitor their blood work, we monitor for all the possible issues that may come up. And if we even see like a 5% chance of a problem arising, then we either stop the medication or we switch it or we adjust it, etc. So having said that, I hope this helps you better understand why there is a push by rheumatologists to treat rheumatoid arthritis with more medications and different combinations of medications upfront. Until next time.